Okay, looks like most folks have joined us now. Good afternoon and welcome to this afternoon's CalAIM webinar series. My name is Mary Ellen Mathis with Health Management Associates, and we'd like to welcome you to today's webinar, Best Practices, How to Employ People with Lived Experience. On the next slide, we can briefly go over today's agenda and housekeeping items. Today's agenda, we'll go ahead and give some brief welcome and introductions, go over our learning objectives, understanding the national and local landscape. We've got a few poll questions for you today, a brief case study, benefits of employing persons with lived experience, opportunities for employing persons with lived experience, a quick group discussion, and again, case studies. And we have some additional resources and opportunity for questions at the end. And then a quick note on some housekeeping items on our next slide. This webinar is being recorded and attendance will be tracked via login. If you have any issues with any audio or visual components today, please feel free to send me, the host, a message. After the webinar, you will receive a copy of the PowerPoint slide deck and the recording link. As a quick note, participants are automatically muted, so please, we encourage you to communicate via the chat. And if we're unable to address any of your questions in today's webinar, we'd be happy to address your questions in an upcoming forum. Then next, I believe I'd like to kick it over to Nancy with HealthNet.
Thank you, and good afternoon, everyone. Welcome to our CalAIM Provider Training Series. My name is Nancy Wambi-Kalev, Senior Director of Systems of Care at HealthNet. This is the fifth in a series of Just as Involved provider training that HealthNet is hosting in partnership with Health Management Associates. We are thrilled to partner with today's speakers who are experts in the Just as Involved space, Dr. Shannon Robinson and Dr. Mark Richmond. Both of our speakers will help us look at best practices for how to employ people with lived experiences in the Just as Involved space. We recognize the important role you all play, and we thank you for helping us implement this very important program across the state of California. We also welcome your feedback and encourage your active participation in today's webinar. With that, I will turn it to our speakers for today. Thank you.
Hi, I'm Dr. Shannon Robinson. I am an addiction psychiatrist, and prior to working at Health Management Associates, I worked in the California Department of Corrections and Rehabilitation. The majority of work that I do at Health Management Associates is to help other correctional facilities, jails, prisons, forensic hospitals, to expand access to evidence-based treatments for substance use disorders, both psychotherapy as well as medications, and to focus on the entire ecosystem of healthcare. So what is like when the person is coming into jail, not just in jail, and what it is like when the person is leaving. So the entire ecosystem. I'm going to let my colleague Mark introduce himself and share a little bit about his experience in correctional healthcare.
Good afternoon, everybody, and it's good to see many of you again. I am Mark Richmond. I'm a psychologist, a practicing psychologist still. I came to Health Management Associates about 3+ years ago. I had a full career, about 27 years working for the state of Delaware. My last position there, I ran Delaware's Department of Corrections healthcare services. So all the medical, all the behavioral health, all the pharmacy services, and had a great opportunity to work with the community, our community partners, and working hand in hand with folks with lived experience who worked inside of our jails and prisons, and also, of course, in the agencies that we referred people to. At HMA, I work hand in hand with Dr. Robinson literally every day, providing technical assistance, mostly to jails and prisons who are trying to either start or improve their addiction services, their treatment services, primarily for folks with opioid use disorder. So I am just pleased to be here today, and let's get started.
All right, so at the end of the webinar, we are hoping that participants will have the ability to articulate the value of persons with lived experience, for sustaining recovery in other individuals, and to outline the options for engaging persons with lived experience in your health plan and in your work, to identify lessons learned and best practices in supporting persons with lived experience working within criminal justice populations. So I previously mentioned the healthcare ecosystem, the continuum of care, and I'm going to come back to that again in a minute. But there is a national strategy. The strategy to address the nation's mental health crisis was outlined in the 2022 Presidential Unity Agenda. And it speaks about strengthening the system capacity, that our current capacity is not where we need it to be in order to treat the number of people who have mental health and substance use disorder problems. And that part of strengthening this system capacity will also focus on connecting more Americans to care. I mean, we can't treat the number of people that we currently have, so we definitely need to do some strengthening. But we also need to connect all the people who are not getting care or not even reaching out for care yet. And that persons with lived experience have a very unique ability to do this, to engage people and to provide people with hope. Persons with lived experience can do things that Mark and I can't do. We've been treating this population for a long time, but that doesn't mean we can actually influence every patient who is sent to us or comes to us voluntarily for care. So it is really, really critically important that we include persons with lived experience. And then we want to create a continuum of support. So I've already mentioned that people are coming from the community, right, into jail, and then they are leaving and going back out into the community. But we need to not just consider the jail, but there is a huge part of the criminal justice system outside of the wire, as they say. So the court systems, probation, parole, the prison system being separate from jail. When I went to work for the prison system, or before I interviewed at the prison system, I actually didn't even know the difference between jail and prison. I had no exposure to justice-involved individuals, no real training. I had some exposure, right? They would sometimes end up in the hospital or in a specialty clinic, but that didn't mean that I had the knowledge base I needed to have in order to take care of this patient population. Additionally, often left out of our conversations regarding criminal justice is the Department of State Hospitals or our forensic hospitals. And then, today's inmate is tomorrow's neighbor. So it's really important that we consider community mental health providers, community substance use providers, both therapy providers and prescribers, because much of the prescribing is actually not happening within our substance use treatment programs. Much of the prescribing is happening within mental health and within primary care. So if you have a patient with complex medical problems, whether that be diabetes and high blood pressure, or whether it be HIV, if they are regularly going to a primary care provider or a specialty care provider like an HIV specialist, then it is most convenient for them to receive their substance use continuum of care from that provider that they're seeing most frequently as well. Mark, you had unmuted for a minute, so I thought you might have a comment.
I just wanted to add, Shannon, that we all talk clinically about evaluating where our patients are in terms of their level of motivation, whether they're pre-contemplative, they're not ready thinking about change, they're contemplative, they're ready to think about change. And most often, my experience in getting folks from the pre-contemplative stage to the contemplative stage has been enhanced by working with folks with lived experience who've been there before, who've been able to say to that inmate, I have been where you have been, and let me show you how I got there. As opposed to Dr. Robinson, Dr. Richmond coming in and saying, oh, today we're going to work on X goal, Y goal. It's that person with lived experience, so critical.
Yeah, it actually revolutionized our practice in the Veterans Administration when we started doing group medication appointments for substance use disorders, because I wasn't trying to tell the person the pros and cons of taking medication. The other patients were telling the patients the pros and cons of taking medication.
Yes.
And it came across completely differently. And the uptake, the retention and treatment was so much better when we made that change. Okay. So you all have seen this slide multiple times already. CalAIM, justice involved initiatives. There are lots of justice involved initiatives. Some of them are for, some of CalAIM is for justice involved. Some of CalAIM is, not just justice involved. There's a lot of things in CalAIM. And then some of it specifically relates to you all as well. You've heard in other talks a lot and are already doing, I believe, enhanced care management. And so I wanted to speak for a minute about the importance of this reentry and reintegration and how that fits in with the work that you all do. We must move away from a policy framework that focuses on punishing people as a tool to control risk, which we know actually doesn't work, in favor of a focus on human rights, harm reduction, and the social and political and economic reintegration of those who have been incarcerated. If we don't have that social reintegration, what is the likelihood that we're going to have economic reintegration? Community engagement is required for us to successfully deliver on this working group's recommendations. So in addition to enhanced care management, where case management for individuals with complex needs, including persons with justice involvement, which is a population of focus. So the managed care plans this is one of the requirements. We also have community supports. Now, this is not a requirement. It is optional for our managed care plans to implement, but it is highly encouraged. And this community support is to support to address the social needs, such as food and housing and transportation. Now, how likely are we to be able to engage someone in employment if we can't keep them stable on their medication? In order to keep them stable on their medication, it is much easier to do that if they have a roof over their head and electricity and an alarm clock, which is usually nowadays a phone. The phone also helps to be a reminder for your appointments and to connect you with your medical team when you have side effects and with your psychosocial therapy team when you need additional support and assistance, and with mutual support as well. Key.
And who best, and if I could add, Shannon, if you can run back up a second.
Yeah.
Who best to help with that puzzle, that piece going from the pre-release to the re-entry, that enhanced case management, and those who've been there, who've experienced it. And we'll talk later, Dr. Robinson, we'll talk later about how we defined those with lived experience to being more than those who've actually been in the system. But let's look at how we can utilize folks with that lived experience, lived expertise, who can help us with that enhanced case management to help with that reentry and community support.
Right. I mean, when I first started doing this work and did the pilot MAT program in CDCR, I was obsessed with making sure that people had appointments so they knew what doctor they were going to see and who was going to prescribe their medicine. And the Transitions Network, who had been doing this work for way longer than me, they're like, Shannon, that's really great from your ivory tower academic background. But, we've been doing this work for a while. Can we give you some input? And I'm like, you can definitely give me some input. Lay it on thick. And they did. They're like, that's great that Billy thinks he's going to go live with Susie when he gets out. But then he gets to Susie's house and finds out that Susie has a dog that she didn't have before he went into jail, and he's allergic or afraid or, whatever. Or he has a fight with cousin Susie and ends up on, Aunt Sally's couch, but Aunt Sally lives on the other side of LA County in Lancaster, not in downtown. You can't go from Lancaster to downtown for your appointment. You just can't do it. And so, people with lived experience, or those who have worked extremely closely and very long with people who have been making these transitions, super, super, super helpful. So what community support initiatives are statewide services that can be provided by Medi-Cal managed care plans that are cost-effective alternatives to traditional medical services? A phone is not a traditional medical service, but a phone sure does help you make it to your primary care appointment, your psychiatry appointment, your substance use disorder appointment, because it provides you, one, an alarm clock, and two, your reminders, because you get a phone call with your reminders or a text message, and three, your calendar. So that's a non-traditional service, but it is a cost-effective intervention to aid with medical services. Community supports are designed to address those social drivers of health, the factors in people's lives that influence their health. Additionally, transportation, housing, food. These services are building on and scaling existing work, such as whole person care pilots that have occurred, health homes, home and community-based service waivers. And although they're not required, they are encouraged, certainly are encouraged. Now, there are 14 community supports that are possible. And I just want to highlight 3 in particular that are really important for this justice-involved transitioning population. So housing transition navigation service. This population is the definition of transition. They are transitioning from a carceral setting back to the community. Depending on how long they've been in jail, or, in my experience and some of Mark's experience, how long they've been in prison, they have not been making a living wage at CDCR. This has actually been in the news recently about the dollar amount that our inmates make in CDCR. They're not making enough to save money for a housing deposit. They're going to have some assistance with that. And then even once they have housing, sustaining those services. So there was, my husband had a hip replacement recently. He's been on the couch for a week. He's had a lot of time to read news. And there was a very, very big article that came out of, I believe, New York City, talking about difficulties in sustaining housing for some of our populations that previously have often been unsheltered because they needed assistance to sustain that housing. And how do they go about sustaining that housing? So I just wanted to point out these 3 of 14 areas that are critical for our patient population that we're talking about. Now I want to shift gears a minute and talk about social capital, the value that arises from relationships. The fact that Mark and I work together every day, that we know we have each other's back, completely different experience from doing a presentation with somebody that I don't work with every day. I know that if I say something stupid, Mark is going to chime in, and he's going to, in a nice, gentle way, let you all know that that I didn't sleep much last night. And my husband's hip replacement is not going so well, and that, like, Mark will set us straight. And so having that relationship where I know that even when Mark corrects me, he's doing it out of your best interest and my best interest, because he wants you to learn as much as possible from this presentation. I'm not going to take it personal if Mark corrects me. That's the power of a relationship. And a lot of us don't have that at work. I'm glad I have that in the team that we work on. So social capital can be accessed and it can be mobilized to help individuals succeed in life, right? Mark makes me better at reaching my goals. Hopefully I make Mark better at reaching his goals as well.
Absolutely.
That is what we're talking about, the power of that relationship. It provides information, but also emotional. Like, I have to trust that Mark isn't trying to one-up me, right? That Mark is, that it's safe. It's okay if Mark corrects me, even in public. And sometimes financial support, although it's much more likely helping with financial navigation and other resources. It also increases the level of trust. It's one of the things that I was talking about with this example, which can allow people to more easily work together to achieve shared goals. Developing trusting relationships based on shared experiences can be extremely empowering, extremely empowering.
In the chat, I just jotted a few words, and if I was able to do a little cycle in the chat, I would. But what Shannon is talking about is relationships equals social capital. Social capital equals having shared experiences, like people with lived experience, equals relationships, right? You will certainly want to talk and express your feelings to people who understand what you've been going through, which then develops your relationships. It's all a feedback loop.
Right. Yep. So emerging practices to use peers in groups to engage participants. And that's what I was talking about. I didn't originally spontaneously have the idea to have a peer-led medication group. And it wasn't a peer-led, but it was certainly, peers were a huge part of it. I did it because I needed to somehow increase access when I had a staffing shortage. But it turned out to be more effective, way more effective than what we had been doing. So the fact that peers can reach each other where we professionals can't. So using peers and groups to engage participants, or in your case, members, okay? To help members build quality and meaningful relationships, to tap into organizational social capital to increase member social capital. And we're going to get back to organizational social capital in a minute. To create space and opportunities that foster organic and real and deep connections. Authentic. To include qualified individuals or alumni in programming and staffing. And to emphasize accountability. This is something that peers, people with lived experience, can do way better than a professional. When it comes from a professional, it seems pejorative. We can say the same thing that the person with lived experience is saying, but it just doesn't come across the same. Even if it's in the same tone of voice, the trust is just much more present, is more palpable with people with lived experience. The use of technology to build relationships, it doesn't all have to be face-to-face, right? Pre-pandemic, we did a lot of these trainings face-to-face, but we found out during the pandemic, we could do a lot of high-quality work virtually. And we can do that in this, in this area as well. And then always using data and logic models for social capital decision making and for evaluation, right? If I didn't have data on treatment retention rates, when I was seeing all of those patients individually compared to when I was seeing all those patients in a group, if I didn't have data, I would have immediately, upon hiring another staff person, gone back to individual appointments for everybody. But I had data to say that wasn't as effective. And by mistake, or, you know, because we had to do something different, it worked, and it worked really well. And so we need to stick with what works. And we know including people with lived experience works. So lived experience, when SAMHSA talks about lived experience, they are talking about three different things: mental health lived experience, substance use disorder lived experience, or criminal justice lived experience. I want to provide the CalAIM definition of lived experience. It means involved initiative. The CalAIM Justice Involved Initiative can be defined as the following: firsthand experience with the criminal justice system, including a history of arrest or incarceration, or secondhand experience, including having a close family member, being a caregiver, or having a partner who has experience with the criminal justice system. When you have a family member that is incarcerated, you learn so much about the criminal justice system that you had absolutely no idea about. Okay, so our next slide is a poll question. So I think Mary Ellen is going to launch our poll. Does your organization employ people with lived experience? Now, I'm going to use the SAMHSA definition here. I'm just going to be very general, right? It could be mental health lived experience. It could be criminal justice lived experience or substance use. And you may not know. And that's one of our options here. You may not know if your organization employs people with lived experience or not. So I'm going to give everybody a minute to answer the question.
And then I have a follow-up question to that.
Answers are definitely still trickling in because we have a fairly big audience. So we'll give this, and we're only at 56%. So there we go. Come on, let's get a little more. A few more responses.
I can break into my Jeopardy theme. All right, keep on going.
We have given it more than a minute. We have, excellent. We're up to 66% participation. I'd love to see a little higher, but I'll take what I can get. Mary Ellen, let's go ahead and share those results. Okay, so 61% of the responders said that your organization does employ people with lived experience. Now, I don't know what Mark's follow-up question is, but my quick follow-up question is, in what positions are those people in your organization? If you could type in the chat how it is that people with lived experience are employed at HealthNet. And then we'll go on to our next slide after we get at least a few responses.
And I can tag on to that actually with my question, Shannon, and do you know, does your organization promote that we're hiring people with
right
experience? All
right.
Right. Peer advocate, counselors, social workers, counselors. All right. One more.
Excellent. Reentry case managers. Yeah. But I think Mark's point about, do you advertise it? Is it valued, or do you know? So I would bet there are a lot of people with lived experience that you have no idea have lived experience. right? Because it's not something we don't generally go around talking to our peers at work, our colleagues at work, about the fact that I have a history of major depression, or I have a history of alcohol use disorder, I have a history of incarceration, right? We don't go around talking about these things.
Great,
right.
Great chat by Noah. And we have a lot of people who have experienced through regular life experiences with mental health, homelessness, justice involvement, and they also have peer support specialists that require it. So they advertise that. Rhonda
yeah,
chimed in, not advertise. Okay, great.
And Noah also raised the important issue of homelessness.
Oh.
Unless you've been homeless, like think about how much stigma exists about those people. Even if you understand that substance use disorder is a chronic disease, we still, there is just a lot of stigma about being unsheltered.
Shannon, look at that last chat. How cool. From Noah, we have an entire team of suicide law survivors, lived experience.
Gosh,
respond to the newly bereaved. Noah, if we could ask,
that's amazing.
Where you work?
Tulare County Health and Human Services Agency.
Fantastic. Very progressive.
Yeah, I'm super impressed. Okay, so we're going to do a case study now. I know that we usually save the cases till the end, but I did want us to have at least one case study as we kind of walk through this. So you are a hiring committee member at your organization, and you are going to hire 2 licensed clinical social workers in a newly formed substance use disorder treatment program within a forensic setting. The job description does not require lived experience. You have 10 candidates apply. Don't know if this has been your experience, but in my experience, a lot of times the people who apply don't actually meet the criteria, but 3 of the applicants do. You extend an invitation to all 3 for interviews, and all 3 schedule interviews with you. You conduct a structured interview where all the candidates are given the same questions, and each person on the hiring committee scores the candidates without discussing their scores with other members of the committee. After the interviews are completed and the scoring is completed, as part of the normal process of selecting the person or people that you're going to hire for the positions that are open, you are discussing the candidates with the other hiring committee members. One of the hiring committee members comments that they did not score a candidate who revealed that they had lived experience highly because they felt that the candidate might relapse in the context of treating this patient population. Remember, in this scenario, you're hiring into a forensic setting. The candidate had specified that they were in recovery from a substance use disorder for over a decade. What are your all's thoughts about this case?
There is so much there, Shannon.
What are your all's thoughts? People might have a lot of thoughts. That's why it's taking. Susan said it right out. That's discrimination. Yes. Bias, stigma, judgment, judgmental, all of those things, right? So at the bottom of the screen, in case people haven't seen this yet, there is a link to the Department of Justice Civil Rights Division paper or guidance, I guess is what you say. The Americans with Disabilities Act and the Opioid Crisis, combating discrimination against people in treatment or in recovery. And it talks about, hospitals and jails and all kinds of things, but also about employment discrimination, and that we can't discriminate against people because they have a substance use disorder or any other lived experience. This case was a substance use disorder, but all right. So what are the benefits of having lived experience? You know, Mark and I have kind of talked about this a little bit as we've gone through our presentation so far. So the link is, yes, we can definitely put it in the chat. Mark or Mary Ellen will grab that off the slides and drop it in the chat. And it
I'm getting it now.
Excellent. It will definitely also be available when you get the PDF of the slides. So I was really amazed, like I knew the benefits of people with lived experience. So when I looked at the literature though, I was really surprised at the overwhelming literature about the value of employing persons with lived experience to work with your other members, to work with participants in your treatment program or whatever it may be. So the members, the participants having increased hope and an actual increased documented objective ability to care for themselves. That's crazy. It's great. It's wonderful. Increased empowerment, increased social functioning and quality of life and life satisfaction, as well as less stigma and increased acceptance of themselves.
And that last bullet point, Shannon, is so critical, right? Obviously, we're working with individuals who already are dealing with a disease, whether it be substance use, whether it be something else, mental illness, whatever it is. So there's already some difficulties with acceptance of oneself. So being able to work with folks who have been there, got through to the other side, or are working on getting to the other side, the decrease in self-stigma, beginning to accept oneself, so critical.
One of the things that I think made this really come home for me is we have compared a lot the opioid epidemic and our interventions for the opioid epidemic to, 40 years ago in the HIV epidemic. And when Magic Johnson came out to say that he had HIV, I'm pretty sure it's Magic Johnson. Please, someone correct me if I'm wrong.
It was.
But when Magic Johnson said that, I think the self-acceptance, the self-stigma improved tremendously. And so we're experiencing the same kinds of things with substance use and with criminal justice involvement now that we did with HIV 20, 30, even more years ago.
With the epidemic, the opioid epidemic being so high for so long now, who doesn't know someone who've experienced, a substance use challenge or a disorder? So yes, absolutely. It's with this unfortunate set of events, it's also helping with self-acceptance that you're not alone.
So we're going to define peers in a few minutes, but since we were talking about data, I wanted to share data with you on are peers effective for mental health and what is the actual data for mental health in particular. So there is moderate support for the use of peers within mental health settings. Compared with professional staff, peers are better able to reduce psychotic and depressive symptoms. Holy cow, right? We tend to think that this is a medication based, issue, psychotic symptoms, but peers are better able than professional staff to help decrease psychotic and depressive symptoms. I'm not saying medication doesn't have a role, but I'm saying above and beyond what that can do, peers can do even more than professionals. Reduce inpatient use and decrease cost of care. So there were a couple of quotes that I thought were really powerful that came from this source linked at the bottom, Moderate Support for Mental Health from SAMHSA. And the quotes were, "When I saw that other people recovered, it gave me hope that I could too. Because of peer support, I am alive." That is profound, really, really profound. And what is the evidence for peers explicitly within substance use disorders? So again, moderate support for substance use disorders to reduce relapse rates, to increase treatment retention, to improve access to social supports, to improve relationships with providers. That's one of the things that I really like is, and that's one of the things that I think was so effective at the Veterans Administration is when one of my patients would say, well, I'm having side effects. And I would say, oh, have you considered, or let's try taking your medication after you eat. The other patients saw that I took side effects seriously. I didn't just blow the patient off. Or when the patient relapsed and I was like, okay, shit happens. Okay, what are we going to do? You know, could you have done something different? Group, what do you think? They saw that I wasn't going to kick them out of treatment, but it's because there was a peer there to model that and increase satisfaction with treatment experience. I can't say enough about including peers.
So if 1 second, Shannon, if you can go back for a second. So we know that folks who end up in the criminal justice system, even if you haven't ended up in jail or prison, but you've been on probation, you've been in courts, you know, many times, particularly those with substance use disorders, have burned so many bridges. They're lacking those social supports. And, you know, having folks, a peer, or folks with lived experience, lived expertise, help bridge that gap to the community. Sometimes they're the only form of social support while somebody's rebuilding their lives. Why wouldn't you want to involve folks with lived experience in our model?
Yeah. Agreed. So SAMHSA defines peer support workers as people who have been successful in the recovery process, who help others experiencing similar situations through shared understanding, respect, mutual empowerment. Peer support workers help people become and stay engaged in the recovery process and reduce the likelihood of relapse. Now, SAMHSA uses a lot of terms interchangeably: peer supporter, peer worker, peer specialist, peer provider, peer navigator, recovery coach, mentor. But I do want to kind of do a little defining of peers versus community health workers. Similar, but not exactly the same. Both are people with lived experience. So California defines a community health worker as a liaison, link, or intermediary between health and social services and the community to facilitate access to services and to improve the access and cultural competence of service delivery. A community health worker's lived experience shall align with and provide a connection to the community that they're serving, right? So if you have justice involvement, that is the community that you're going to serve. If you have substance use disorder, you would serve that community. So when you compare peers versus community health workers, there's a lot of overlap. However, the focus is a little different. So with a peer, their focus is more one-on-one, and the community health worker might be providing some one-on-one services, but is also doing more kind of population health service engagement. So that wider outreach. So peer support workers, their scope includes a sharing of experience and mentoring, advocating, sharing resources, helping the person to build skills, building community and relationships, facilitating recovery groups, setting goals, linking, monitoring, coordinating services. And the community health worker does more wider community outreach, does assessment as well. But they both do advocacy. They both share resources. They both educate and facilitate, link and navigate. And then the community health worker may also be assisting with benefits applications and supporting reentry. There is a tremendous amount of overlap, though. There are actually national standards for peer support certification. And we're not going to spend time talking about those standards, except for, I do think that we should go deeper into 3 of these standards. And those 3 include authenticity. So being authentic. Part of being authentic is having that lived or living experience. So lived implies past experience, not current experience. Living experience implies current experience with a mental health or substance use disorder, or currently being involved in criminal justice system. But we need to remember that mental health and substance use disorders are chronic in nature. So the term lived experience can refer to both current and former experience. Don't get caught up in the semantics here. Background checks. This is a massive barrier to getting hired. So it is, I believe it is important that we look at the recommendations that are provided by SAMHSA here. And the recommendations are that background checks be conducted by employers, not certifying bodies. So like the certifying body shouldn't say you can or can't have a job because you have a mental health, SUD, or criminal justice background. The recommendation also is that if the employer has disqualifying offenses, that those disqualifying offenses actually be restricted to things that pose a risk to the population being served. So a misdemeanor drug charge or a non-violent felony shouldn't even be asked about. This is the recommendation from SAMHSA. The other recommendation is that there need to be clear timelines established so that you're not asking about an offense that occurred 10 or 20 years ago. Mark?
So I want to spend a couple more minutes with this one, because as Shannon said, this is enormous. Typically speaking, and historically speaking, most jails, most prisons would say, if you've been part of the system, you ain't coming back in to work with us, right? Where we just can't allow that to happen. You're too much of a, quote, security risk, end quote. Over the course of the last 5 or so years in particular, that has mitigated a lot. Because I think of the approach that that organizations like SAMHSA has taken, because of the momentum that advocates are bringing to the table now, to say, let's talk about individual situations, individual cases. Let's look at who can be most helpful to folks coming out of jail, coming out of prison. If you have a background clearance that says any misdemeanor, any felony, then you are losing out on people who could actually help, because again, they've been in the shoes of folks that are on the other side of the wall. And if you have very, very strong policies, that's not to say that you can't change policy. One of the jails that we work with, for example, went from an absolutely no way, no can, no how to, okay, well, maybe we'll allow certain folks in with less than desirable criminal histories, but first they're going to be supervised by a custody officer as they walk around the tier, to eventually saying, all right, this person has basically proven their worth, proven that they're safe, and then they're given full access to the tier. So just because a jail says no way, no how, don't give up. Push, push, push. There's ways to get around it.
And Noah brings up a really great, some great issues in the chat about education and experience often being lacking. One of the reasons that so much effort is going into peer certification and community health worker training programs is for exactly this. And those training programs are like 40 to 80 hours. So they're not super intensive, but yet you come out with a workable amount of knowledge, and then you have to put in a certain number of hours, supervised hours, as Mark was just kind of talking about, supervised hours. And there are regulatory or legislative barriers that sometimes exist. So it may not just be like an organization or a county jail has had this policy, but it could be a state has this policy,
Right.
or these kinds of things. However, policies, regulations, laws can change. And so it's incumbent upon us who know the value of people with lived experience to really advocate for them. And Noah, your point about lower paying jobs, that is one of the things that comes up with SAMHSA and with the Bureau of Justice Assistance. So we'll get there in a minute. Hopefully I included that in the PowerPoint. The third thing that I want to spend some time talking about from the standards is recovery. And what the heck does that mean? And it means different things to different people. And some people may say recovery means abstinence, but you could be abstinent and not in recovery, in my personal opinion. But abstinence even means different things to different people, because some people will see it as abstinence from your drug of choice, where other people will see it as abstinence from all illicit substances. But it's okay if you have alcohol and marijuana, or other people will see it as other things. So the recommendation that abstinence-based verbiage not be included as part of your job postings or regulations and requirements. SAMHSA's working definition of recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential, which I personally think is beautiful. All right. Even the Bureau of Justice Assistance has best practices for retaining peer recovery support specialists. This came out actually when we were talking about doing this presentation. So I was really glad that we could include some of these things that they're recommending. So they're recommending clear expectations about the role of the person with lived experience. And I think that that helps our custody officers and our justice partners to understand what this person is going to do and what this person is not going to do. Very clear, not just expectations, but job descriptions as well. And then providing ongoing opportunities for training. That was something that I really loved. I know that that's one of the ways that CDCR helps retain employees is by having lots of special programs where people can go on and get further training. Providing opportunities for advancement. So that's something that I've noticed in a lot of governmental job postings, is that it'll say education or equivalent experience or X years of experience. And then the other thing that I think is super important and probably hasn't gotten enough focus is that the supervisor must have a strong understanding of the intent, the scope, and the boundaries. Because if the supervisor doesn't have lived experience, then working with someone with lived experience can be unsettling for them. They just, especially in our criminal justice population, as it was in the case that I presented at the very beginning.
And I will go even a step further, Shannon, and say, when we're posting positions, when our MCOs are posting positions for enhanced care management or other positions where we are encouraging folks with lived experience to be hired, this should be a checklist for your posting. Does your posting have clear expectations, job descriptions? Is in it opportunities for advancement and training? And what is essentially going to be the role of a supervisor in working with folks? So use this as a checklist.
Yep. Okay, Mark, I'm going to turn things over to you for our group discussion.
So we've already gotten some great feedback and questions and comments. We want to use the next two case studies to generate even more and get you really putting on your thinking hat. So on case study number 2, I want you to meet Jose. He's a 39-year-old former detainee and former inmate, meaning he's been in prison, not just jail, who has battled a substance use disorder and mental health issues during his time both outside and inside jail and prison. So what we call co-occurring, right? Mental health and substance use problems. Over the course of his multiple stays, because he's, as with lots of folks with SUD and mental health problems, they're in and out of jail. Over the course of his multiple stays and episodic treatment in jail and prison, he began to recognize the need for emotional healing and connection among detainees in the large county jail where he worked as a peer navigator. So now he's working inside the jail as a peer navigator. After his release and successful recovery, he returned to the jail now as a peer facilitator. Jose wants to collaborate with the local county behavioral health agency and community local mental health organization to assist detainees, these detainees, to re-enter into the community. So now this is the input that we need from you guys. What areas do you think Jose should focus his work to establish first rapport and second, begin the release discharge planning for these detainees? What areas should Jose focus his work on to first establish rapport and 2, begin that journey of release discharge planning for these detainees? So we will welcome folks coming off the chat or just coming off mute or entering into chat. What do you guys think?
We're helping you write your job descriptions.
Can you monitor the chat?
Yeah.
Okay.
It's a collective job description writing.
Yes. Folks. No, I think Noah just chimed in. If he has the support of the administration. What administration? Are we talking about jail administration or county behavioral health?
Wherever he's employed, whoever he reports to.
Okay. And sometimes folks who are peer navigators, peer facilitators are either employed by the jail themselves, which is what we really love, or a community agency. So they could be either one. Good point, Noah. He could join the mental health, behavioral health board and public health advisory meetings and provide information about his intent, essentially to pitch his idea. And then he can then get linked with staff and build relationships. Very, very good. I love this one. Getting linked with additional organizations such as NAMI, the National Alliance for Mentally Ill, and work training organizations might be helpful as well. Excellent points. Anybody else? What areas? How is he going to start to build that rapport? Begin release discharge planning. Who should he work with? He's just one person inside of a jail, working inside of a jail.
So Mark, it's possible that of our participants, they have not worked inside of a jail. So it's possible that, like I said before, I interviewed at CDCR, I had never been in a jail or a prison or a Department of State hospitals. So they may not know enough about the structure within the jail about who he should work with.
That's a great point, Shannon. Let's assume that they work for a community organization, mental health or substance use treatment organization, and they are employing the peer navigator and peer facility. Who should they work with? With the community organization.
Yeah. So Noah says they should probably need contact with the sheriff or the sheriff's administrative staff, right? Or else things won't go anywhere. And I 100% agree with that. If you do not have buy-in from the sheriff and the jail admin staff, you are not going to be successful with this endeavor of people with lived experience helping out in this situation. Yeah, definitely. So Mark, I would propose some questions to you, or bring up some scenarios. Sometimes people get funding for reentry positions in a jail or maybe in an NCO, I don't know. And the position was funded for one reason, but the person gets taken away from that position and is really not doing reentry work and is doing something that is viewed as more critical for the organization. So reentry statistics may not be very good. There was a person hired into the position, but the person actually isn't doing the work that they were hired to do. They're doing some other work that the organization considered to be more critical.
Any thoughts from our group out there? What should they do? Right? They were hired for one reason. They're doing something else. Now, maybe that individual is just happy to be employed and to get some job history by working in whatever role they have. But what perhaps might they do? Well, I can certainly, we're always trying to teach our folks to advocate for themselves, certainly. Now, we also know that we just got done talking about that job description being really crystal clear, so that individual can always go back to what they were hired for and have a conversation with either the hiring individual or human relations department, whatever it may be. But I would certainly want that individual to see what they can do, what they enjoy doing, what they want to do, because ultimately what we're trying to promote for anybody who is making a life change is to grow. And if their position changed somewhat from what they were hired to do, is it providing that individual growth? Is it positioning themselves for that last check mark we talked about a couple of slides ago, for their own advancement? Can it help with their advancement? Anybody else have any thoughts? We can move on to the next case study. Should we?
I would say data, though, is really important.
Data. Yep.
Yep. So in the MAT program, during the pilot phase in CDCR, there was extremely good attendance at first appointments. Actually, twice as good as for our severe mental health patients or for our HIV patient population. But that demonstrated the power of if you have a dedicated person to do reentry. And that data allowed support of additional positions.
It's interesting you say that, Shannon. It brings back when I was in Delaware and we were pitching the wardens of the jails to let us allow folks who've been previously in the system to help us work with the current inmates. One of the things that one of my folks with lived experience proposed to me, that he said, how about we keep track, he didn't use the word data, but let's keep track of the people that I work with to see how many of them end up coming back to the jail, right? That's a way of getting data. Now, maybe it's not going to be published in a journal, but it was like, hey, I worked with 6 people over the last month, and 3 months later, 2 of them came back to the jail. Well, that means 4 of them did not. And 4 of them were on their way to a better journey, or at least we hope a better journey. So that data point is really well taken, Shannon.
Okay, I'm going to move us on to our next case, Mark.
which is actually my favorite case, I might say.
Okay, go for it.
All right, case number 3. I want you to meet Joseph, a 29-year-old former detainee who struggled with finding stable employment after his release, which frequently resulted, what a surprise, in ongoing criminal activity, right? Couldn't get a job, so he ended up ongoing criminal activity. But after accepting help from another individual with lived experience, he decided to make a difference for others facing similar challenges. Really the definition of lived experience right there, right? Joseph acknowledged that not having a high school diploma or trade has impacted his ability to live the straight and narrow life in the community. Now, Joseph is now back and he wants to help detainees who do not have a diploma or trade to either start inside the jail or, because sometimes we don't know when people are released from jail, to establish a feasible plan in the community, right? So either start in the jail or get them on a plan to start it in the community or continue it in the community if they're released. He plans on collaborating with a nonprofit organization that focuses on providing educational opportunities to incarcerated individuals. He wants to help detainees with developing skills like resume writing, interview skills, and professional networking. All the things that Joseph, by the way, learned from another individual with lived experience. So the question for you guys to think about, to chew on, how might Joseph introduce this concept to the jail administrator? What things should he talk to the community organizations about? What about developing a GED program inside the jail if there's none there? Who should he talk to? What strategies should he think about in talking to any construction firms who offer road construction traffic flagger programs, right? The folks that are holding up traffic while they're doing construction. Who can come in and teach these programs? Who should Joseph talk to? Looks like, I think the first step, Noah's chiming in, is to search for programs similar to what he is thinking and learn as much as he can about those programs, such as their model, partners, and let me scream to the top of my voice, costs, right? If you're gonna talk to a jail administrator or somebody from the nonprofit community, you wanna know what it's gonna cost. Who's gonna pay for it? Yes, to prepare for a meeting with folks up the chain. He also might like to link up with various trade unions. Oh, excellent idea. Didn't think about that. To see about pathways as well as his adult school regarding their program's willingness. We know that construction firms often allow folks who have lived experience in the criminal justice side of things, right? So going to talk to the head of construction firms, of carpentry firms, how they can bring some of these programs or at least link connections for the detainees who are going to be leaving back when they're out in the community. Our re-entry navigator, our person with lived experience, can do that warm handoff, not just to a treatment program, but also to some vocational trade programs, right? To some job interviews. Our jail navigator, our person with lived experience can help our detainees with perhaps interviewing skills, right? They're meeting with individuals inside, right? No different from meeting somebody in the community to help them with, for example, making eye contact, speaking clearly, right? Interview skills. What better way to learn than to speak to somebody who's lived it themselves? Any other thoughts? Any other questions about our friend Jose and what he may do?
So just to emphasize some of the things that you said, I mean, education, vocation, and substance use treatment are the things that have been consistently shown to decrease recidivism. And the fact that many of, whether it's patients in the substance use treatment program back when I was in the VA, or many of our incarcerated persons haven't worked jobs that required formal job interviews and may not have had any mentoring on what is appropriate clothing to wear to a job interview. And how do you interact during a job interview, and preparing responses for difficult questions.
So in a moment, we're going to show you some resources on the next slide. But if you take anything from the last hour or so, look, the expectation that we have now is to hire folks with lived experience. Look at how our organizations can be enhanced and how we can serve the people that we need to serve by hiring folks who've been in their shoes and who can help us essentially get people on the right track and their journey into the community, just like Joseph did by working with another individual with lived experience, turned his life around. We can hire people in those same roles and make a difference in people's lives. Shannon?
All right. Want to run us through these resources?
So we have a couple of resources here that you'll get the slides, obviously, but really take a look at these resources. Some great pieces of information. You don't have to read them front to back, but have them as resources. The first one from RTI from UNC is the peer support as a social capital strategy for programs serving individuals re-entering, right? Coming out of the jail, coming out of prisons. Great resource. The second one, which I like, I've seen and I've looked at a few times, is from the Brookings Institute. It's on it's a chapter of a larger book on prisoner re-entry. Right, I think it has a number of things that, once we hire folks with lived experience and they're going to go into the jails, go into the prison, some great resources inside that chapter to take a look at. And then finally, another publication by RTI is about the value of relationships, improving human services, participant outcomes, again, through that social capital that Shannon talked about earlier. Authentic relationships. Any questions? Comments? Restaurant recommendations? No, just kidding.
So we do not lose people before the evaluation is done. I do want to make sure that people know that when the webinar has concluded, a survey of questions will open in a separate browser window. And I would like to take the slides down for a minute. I think you and I might be the only people who are on camera, but I'd love to know if there's anybody else on camera, if anybody has any questions before we come to a close today. And I do want to thank everybody for their participation. Very helpful to have people participating.
Well, we can certainly give people some time back, Shannon, can't we?
We can, especially at the end of our day. It's definitely the end of Mark's day. He's not in California. He's on the East Coast. So
thank you.
All
Outstanding,
right.
folks. Outstanding. Thank you all so very much.
Have a wonderful day. Bye-bye.